All right, folks. Just first off, I want to apologize that I was unable to get everything situated and get your lecture uploaded whenever I was supposed to. Had some issues between home and technology issues have not been my friends this past weekend. I have tried everything I knew. Finally, got to meet up with Best Buy, and they know a lot more than I do. So we're going to hit this lecture, get it done, get you situated. I will also reschedule the due dates of this class so you guys can um, have plenty of time to take your test. I know that I'm posting this today, and then we'll have a class tomorrow on Tuesday. So basically, you have three this week. So I apologize for that, but it unfortunately it is what it is. We'll have to get from there. So talk about medicine. We know about our national EMS standard and competencies. These are the ones that we've always go over every single time. So it applies the fundamental knowledge to provide basic emergency care and transportation based on assessment findings of acute ill patients. So we're going to talk about diseases of the eyes, ears, nose, and throat, recognition of management of nosebleeds, what we can do in the field, how we can help fix it, what we can and can't do. Really, that's just kind of go over the big bases of it. So they're also saying that trauma applies to the fundamental knowledge to provide basic emergency care and the transportation based on assessment. It's kind of the same thing we just read for medical, but we're gonna touch it all. We're gonna get y'all some knowledge. All right. So the on number four of our competencies, we're going to talk about head, facial, neck, and spinal trauma. We're going to recognize and management of the life threats. We're going to talk about spine trauma, patho assessment and management. We're going to talk about penetrating necks and laryngotracheal injuries. Just kind of give y'all an overview, kind of say the 1,000-foot level, give y'all an idea what to see, recognize, do, go from there. Figure this out. Other parts we're going to talk about spinal trauma, facial fractures, skull fractures, foreign bodies, and dental. I don't like dental. I don't like eyes either. So y'all just go ahead and let y'all know that up front. Okay, so here's an introduction. Let's see. The face and neck are particularly vulnerable to injury because they're relatively unprotected portions of the body. They're out there. They're pretty big on every single one of us. No matter if you say, "Oh, he got a big head" or not, they're not really protected. They're, it's on an island by itself, basically. Soft tissue injuries or fractures are common and vary in severity. Some injuries are life-threatening, but penetrating trauma to the neck may cause severe bleeding. An open injury may allow air and embolism to enter the circulatory system, which none of those are good. Penetrating injuries are not good at all because we can't do nothing to fix that. Especially depends on where it's at. You may have to stabilize and transport with the way that it's at. We may turn around and have to treat that air embolism, and what we gonna do? What we gonna put over it? How we gonna keep it from going? All right, so if a hematoma forms in this area, it may stop or slow blood from the brain, causing them to have a severe stroke. Okay, so with appropriate pre-hospital and hospital care, a patient with seemingly devastating injuries can have a surprisingly good outcome. Depends on your care. If your care is worth and is good and up to par, and you keep up with your skills and everything's good to go, it's gonna be good. We're gonna have a good outcome, hopefully. But as everybody else does, we can't fix everything in this world that we're gonna see out there. So we're gonna try our best no matter what, and we're going to do the best for the patient no matter what. All right, so we're gonna start at the top. If y'all don't know that it's called the cranium, we might need to start back over in grade school, but we're going to go down from the head down. All right, so the head is divided into the following parts. So we're going to talk about the cranium first. It's also referred to as the skull. It contains the brain. Like I said, we're gonna keep this simple for some of us. We're gonna keep it simple. The brain connects the spinal cord through the foramen magnum, a large opening at the base of the skull. The most posterior portion of the cranium is also called the occiput. I probably pronounced that wrong, but we're gonna let y'all read right here. If I did, one of the on each side of the cranium, the lateral portions are called the temples or the temporal regions. Y'all know where that's at because y'all massage your head when your head starts hurting. And then between the temporal regions and the occiput lie the parietal regions. The forehead is called the frontal region. Anterior of the to the ear in the temporal region, you can feel the pulse of the superficial temporal artery. So y'all should know where that's at. If not, start playing with yourself. Feel it behind your ear, fall down from the temporal region. Oh, look, there's a pulse. So if y'all didn't know that, surprise, you learned something today, whenever you're watching this. All right, so here is the components of the face. We all have these in some form or fashion. Some have bigger ones than other ones. I'm just picking. We're just trying to lay some jokes out there. So with all that being out there, we're gonna go on further. All right, so here's a picture of the face. This is probably what you need to know right here. 6 major bones include nasal bone, 2 zygomers, 2 maxillae, and a mandible. Here you go. These are the bigger ones that we need to know. So, oh, I think I'm already yawning. I don't know what the deal is. So the orbit of the eye is composed of the lower edge of the frontal bone, the skull, the zygomae, the maxilla, the nasal bone, and the bony orbit. This is what holds your teeth in, and then your nasal bone that your nose is connected to. See, we're learning something, folks. Only the proximal third of the nose is formed by a bone. The remaining 2/3 are composed of cartilage. So, like like to pick on people, the little flappy parts of your nose is all cartilage. Your bone, when you break your nose, is high. It's high in your nose. All right, so the exposed portion of the ear is composed entirely of cartilage. I hope y'all knew that. The visible part of the pinea, the tragus, is the small, rounded, fleshy bulge immediately anterior to the ear canal, and the superficial temporal artery can be palpated just anterior of the targus. Right in the ear, up in there is where you can feel it. Let's go over this again. Mandible, 7 cervical vertebrae are down through here. Your occiput, your pinna, that's just the outer part of the ear. That's like the wrestler ear. That's always what swells up, messes up, and that's where your jawbone connects to your phabis. All right, so the face, about 1 inch posterior to the external opening of the ear, is the mastoid process. So bony mass at the base of the skull. The mandible forms the jaw and the chin, like we just showed you on the pictures. The jaw is the lower border of the mouth where the tongue and 32 teeth are located. Motion of the mandible occurs at the temporomandibular joint, which lies just in front of the ear on either side of the face. Below the ear and anterior to the mastoid process, the angle of mandible is easily palpated. There's a picture in a minute. Maybe not. Right here. So this is where they're talking about right here. That's what they want you to see. All right, so the neck. This one goes a little deeper now. All right, so the neck contains important structures. Supported by the cervical spine, the first 7 vertebrae in the spinal column, C1 through 7. The spinal cord exists from the foramen magnum and lies within the spinal canal formed by the vertebrae. Excuse me. The upper part of the esophagus and the trachea lies in the middle of the neck. The cricoid arteries are found on either side of the trachea, along with the jugular veins and several nerves. Bam, there's a picture. All right, so the larynx, the Adam's apple, is located in the center, right here. There you go. All right, so it is formed by the trichoid cartilage right here. You see that little bump? That's the blue. All right, more prominent in men than in women. Yes, it is. We're gonna leave that there. The other portion of the larynx is the cricoid cartilage, a firm ridge of cartilage below the cricoid process. So right here is the cricoid membrane. That's if you have to if you heard somebody saying they got to cut down a cricoid, they cut it here and put a tube in there. It's very rare that we've ever done that. I've never done one, or its ability to do one. but that's where it happens at. So this is the cartilage that they're talking about right through here. This is what forms the Adam's apple in men. All right. Oh, look at there. There it is. Bigger picture. There's the little V. If you had to cut and stick a tube, a pin, that's not still going to work, but it goes right there. All right, the cricoid membrane lies between the thyroid cartilage and the cricoid cartilage. Soft depressions in the midline of the neck, a thin sheet of connective tissue that joins the two cartilage. So the best way to figure it up, get a guy that if they don't mind you poking on their neck, get them to look straight up at the ceiling, and you can start to feel. You'll feel this part stick up real first. You probably won't feel these. You'll feel the opening, and then you'll feel the bottom. Now, if you poke right through here, it is very uncomfortable, but you can feel it, and you can start to feel some of the trachea rings as you try to step down, and then it's going to stop because it's going deeper into the neck and to the fatty part. So this is your Adam's apple. You're not going to feel any of this. That's the base of the tongue, but you'll feel this. If you have the male look straight up, you should be able to feel it from there. Just giving you a little idea. All right, so the trachea. Did we just talk about this? Nope. All right, below the larynx. The trachea comes to the oropharynx and the larynx with the main passages to the lungs, which is the bronchiole. It's going to connect to your left and right lung. Sorry. On either side of the larynx and the upper trachea lies the trichoid gland. Bet y'all didn't know that, did you? Uh, I'm not even going to try to pronounce that. Yes, I am. Sternocleidomastoid. I'm going to badger that up. This originates from the mastoid process of the cranium and inserts into the medium border of each collarbone and the sternum at the base of the neck, and it allows the head to go from side to side, moving forward, backwards. It helps with the movement and gives them the ability to move. Really, I guess that's how you put that. All right, so here comes the not so nice part. So the eyes, the globe shape, it's approximately 1 inch in diameter. Some's got bigger ones. Located with a bony socket in the skull called the orbit. Y'all know that. The orbit is composed of adjacent bones of the face and the skull. In adults, the orbit protects an overall of 80% of the eye. Between and below the orbits, the nasal bones and the sinuses. The figure, let's see here. So this is your pupil. That's your lens that reflects the light and all that. So everything is reflected back up in here. Your iris, your anterior chamber, your posterior chamber, which is pointed to the red spot, which is you can kind of right up in here, right behind. I'm sorry, right here is the pink stuff. But your lens is what reflects it when it flips it around and does all the cool stuff. Um, you can see some of the veins in some people's eyes. You can see them predominant more than others. You can sometimes if they had trauma, you'll be able to notice it sticking out more. All right. So the eyeball or globe keeps its shape as a result of pressure from the fluid contained within its two chambers. A clear jelly-like fluid near the back of the eye is called the vitreous humor. It's not funny. I'm sorry. No, I'm just picking. All right. So in the front of the lens is a clear fluid called the aqueous humor. In penetrating injuries of the eye, aqueous humor can leak out. With time and appropriate medical treatment, the body can make more. Oh, I don't. That's. I don't like that. The conjunctive is the membrane that covers the eye. That's what you get like when it gets down in here, the conjuncti, which is the red part of the. If you pull your eye down like they're doing right here, the little pink part on the inside of the eye, that's where they're talking. Sclera is the white part, and that's when you'll notice like when they have conjunctive, when the eye is infected, this will be a different color. It won't be clear and white. Yeah, iris is the color part. It gives you your color. Your pupil is the dark part, which you always want to keep round and reactive to light. And the lacrimal gland is right above the eye. So here's your eye ducts that you always get the little crusty boogers in the morning. That's where it comes from. It's right in here. Just so y'all know your landscapes. I figured you already knew that anyway. Sclera is a white fibrous tissue that helps maintain the globular shape and protects more delicate inner structures. Here, on the front of the eye, the sclera is replaced by a clear, transparent membrane called the cornea. The iris acts like a camera and adjusts the size of the opening to regulate the amount of light that enters the eye. The iris is pigmented and it gives the eye color, like we just went over in the picture. Kind of gives you some input. So the pupil is the opening in the center of the iris and allows light to move to the back of the eye. Sorry, I was having to think something else. Anastoria is a condition in which a person is born with two different sized pupils, and that will kind of give you an idea that they have had head trauma at one time because it's different sizes. And unconscious patients' unequal pupil size may indicate, oh, look, I just told you right there. It may indicate brain illness or eye injury, so be cautious of that. The lens lies behind the iris, and the lens focuses images on the retina and at the back of the globe. Let me get my yawn out of the way. So, if you notice that a pupil is blown, you can always ask them, have you had eye injuries before? Have you had born with different ones? And they're like, no, why? You're just checking. I want to make sure everything's good. You don't want to freak them out and tell them that their eyes are blown or like the pupils are blown or something. So the retina contains nerve endings which respond to light by transmitting nerve impulses through the optic nerve to the brain. You know, like when certain things are super bright, everybody's like, "Oh God, what was that?" Oh. The retina is nourished by a layer of blood vessels between it and the back of the globe, and they are called the cricoid. I guess that's how I'm gonna say that. I'm gonna look right there. I'm circling it. Retinal detachment is when the retina detaches from underlying cricoid and sclera, causes blindness. So yes, and if you happen to notice that it will freak you out, and they can't do anything, their eyes, all they can see is white. You want to get them to close their eye, cover it. Maybe if you have a patch on the truck, and transport quickly, because there's nothing we can do about that in the field. All right, so injuries to the face and neck. Whew. Injuries about the face and neck can often lead to particular and complete obstruction of the upper airway. Because of its location, is why they say that. Severe factors may contribute to the obstruction. Blood clots in the upper airway from heavy facial bleeding, which requires a lot of suction. Direct injuries to the nose and mouth and the larynx and the trachea are often sources of significant bleeding and respiratory compromise. Lean them forward, don't make them lean back. And you're gonna have to require suction for that. Period. You gotta suction. Injuries may cause your teeth or dentures to become dislodged into the throat. And if you can, get them to spit it up, collect every bit of it, and transport, because they may be able to put the teeth back in. Let's see here. Swelling that accompanies direct and indirect injury to soft tissues can contribute to air obstruction. The airway may be affected when the patient's head is turned to the side. Now think about that. Why would it do that? So if the swelling is on one side or the other, and they may not be able to, uh, if they turn that way, it's going to be constricting on the airway. So they're going to be wanting to face whichever way is the least restrictive, and they're a bit of breathe. Sometimes it is facing forward. You may see them want to lean to the left, or if they have worst case scenario, tracheal deviation, and then you're going to face issues on getting that because you'll notice it be like, oh, what? Why is your throat on your left side? It's not mid sternum. It's what's wrong with that? So you'll be able to catch that. This is often the case with altered level of consciousness or unconscious patients. Possible injury to the brain and or cervical spine may interfere with normal respiration. So you may catch yourself having to bag individuals like this. You may want to put them on high flow O2, but watch their respirations. Or are they labored when they breathe? Or are they just not breathing adequately enough that may require you to bag them? Um, If the great vessels in the neck are injured, significant bleeding and pressure on the upper airway are very common. So look at this one right here. So unfortunately, this sweet person, I don't know which one it is, probably took a slip, trip, and a fall. And you can tell all the bleeding is here to the back of the head. That sweet person now is in a lot of injuries. Um, soft tissue injuries to the face and neck are very common. The face and neck are extremely vascular, so they're going to bleed a lot. Unfortunately, elderly will bleed a whole lot more. Skin and tissues in the area have rich blood supply, so think about why that is. Because again, it's very veiny, and they're going to have veins to blood vessels to the top of the skin. Bleeding from penetrating injuries may be heavy. It depends. Like if it's through the cheeks, they will not bleed at all or very little. Even minor soft tissue wounds to the face and neck may be profusely because of how vascular the area is. A blunt injury can cause a hematoma. Sometimes a flap of skin may be peeled back or avulsed. Probably this young person right here probably has an avulsion right there, where the skin's probably pushed up or been split. I just poor person. I hate to see that. So dental injuries. These are kind of start talking about your teeth and how to preserve the teeth and treatments. All right. So dental injuries, mandible injuries are common causes of its premise. Secondly, only the nasal fractures infrequently. Most of these fractures are the result of vehicle collisions and assaults. Signs of mandible fractures include, you see those right there, misalignment of the teeth, numbness to the chin, and the ability to open the mouth. Maybe their jaw's broken. They're like, oh, okay, oh, it hurts so bad. It's because it's broken. They'll have to wire that back and suck fluids out of a straw for the next couple of months. Easy things. Maxillary fractures, are usually found near after a blunt force. When we say high energy impacts, maybe they were on a motorbike and ran into a wall. That's a high energy. MVCs, not just slip, trips, and falls are going to cause a maxillary fracture, but unfortunately, everything's possible until proven otherwise. The signs of maxillary fractures, you see those three right there. Fractures in the vol's teeth are common following facial trauma. Teeth fragments can become an airway obstruction and should be removed immediately. If you can, allow them to spit them out, and or you suction them out, or you use McGill forceps. Never put your fingers in there to remove anything that the patient may turn around and bite down, because now your finger may become a lost object and they may choke on it. Yeah, that's kind of, I want you to explain that one to med control. All right, so we're going to size up the scene. What do we see? Upon arrival, observe for hazard threats. We know that. We're going to have our PPE on. We're going to make sure all of our standard precautions are taken care of. If there's, projectile bleeding, we want to cover them up, get our eyes protected. If you have to change gloves multiple times, I've learned over the past, go with a smaller set of gloves on initially and put your, like if I wear a large, I'll put a medium on first and then a large on top of that. Multiple layers of gloves can reduce your feeling, but it is easier to change gloves when your hands get slippery. You can peel off a set of gloves and then you already got another set of gloves on. And then once you guys know, if you've done it in the past, is you wear these gloves and your hands start sweating, it's hard as hell to get your gloves back on. So keep that in the back of your mind. And then as we're sizing up the scene, how many patients do we have? What is their MOI? What in the heck is going on is what we need to figure out. We need to know, we talked about the MOI, assess the scene. What injuries do I see to the face? Are we coming from a motor collision, a sports event, football, slip, trip, and fall? Is it penetrating or is it a blunt force? We need to know these things or have ideas of these things so that we can treat them in the most appropriate way and continue to go from there. Um, it helps us with our treatment when we know we haven't, I say not know, but we have ideas of these things. So it's the reason why we want to try to size it up the best that we can. So our primary focus is always going to be on life-threatening issues. If it's a life-threatening, stop and fix it. Treat your ABCs, no matter what injury, always treat ABCs to begin with. When you start doing your skills, you should know ABC or scene safe BSI, which means body substance isolation. I'm going to treat my life threatening concerns and my ABCs first. And then what do I see? And go from there. That's your route uh, of care that you're going to provide. So that's the reason why I'm telling you to always, this is always the same. So just remember your size up. Majority of your assessments are always going to be the same until it's trauma related. But your BSI scene safe, your treating of your life threatening injuries, and your ABCs, 100% the top three things. General impressions. What do I see? Is there copious amounts of blood? Are we able to control the bleeding? Are they responsive? Do we have to hold spinal immobilization? What is the patient's condition? Are they unresponsive? Are they unconscious? Are they, what do I see and how do I treat it? No, I'm just kidding. I hope you know how to treat it. I'm just trying to change things up. So always assess your airway. Like we just said, what's their LOC? I need to know what the decap BTLS is for the chest wall. Is it stable? Is it unstable? Are they able to hold air? Or do they have proper ventilations, proper chest movement? Um, if we splint them, how are we to splint them? Are we to splint some side to side? There's several things that we need to know. So you have to check that. I gotta remember how far we are. It's 30 minutes. All right. Circulation. I tell you what. Hang on one second. I need to run do something real quick. All right, my bad. So when we check these things, we want to make sure their skin condition, color, and temperature. What is the pulse? Do they have PMS times 4? Significant bleeding? Is it a life threat, or can I fix it with a direct pressure? Elevation? Is it clotting on its own? Those are very important things that I need to assess. So then we're going to figure out what we need to do with them. Are we going to treat them? Can we treat them? Or is it something that I need some help with? Do I need an ALS support if we're on a full BLS truck? And what particular hospital, what kind of hospital do they need to go to? Do they need a trauma center, local band-aid station, or another assessment of a facility? That's what you need to know when you get your your assessments of your patient. Okay, this dude's going to need a trauma hospital. This guy's going to need a stroke facility. That's what they're looking for. There we go. Talked about transport precisions, and the reason why we talk about the hyperperfusion is because if there's a lot of blood, you're gonna notice the tachycardia, the tachypnea, tachypnea, low blood pressure, weak pulse, and all that is because of their vascular system is going away. They're losing these mass amounts of blood, and that's why you're gonna notice these signs and symptoms right there. Primary assessment, we are going to say the patient who has the significant MOI but whose condition appears stable should be transported promptly. They go first. Remember that the significant blow to the face or throat should increase your suspicion of a spinal or brain injury, so they could be having a TBI also. Even if the patient has no signs of hyperfusion or other life-threatening injuries, there's always a possibility for eye injuries, like we said it there. And you can consider the other ones. Surgery is also going to be, but you got to get them there pretty quick for that to happen. History. If we're able to take a history, let's get a good one. I want to know my sample. I want to know what's the last thing they remember. Do they remember anything? Ask the people around. Where it says there, be aware of pertinent negatives. Know what they talking about. What throws you, what catches your attention, to figure out what Hey, do they really know what's going on, or am I trying to piece this together? So your secondary assessments are going to be slower, be each individual system, full head, arms, chest, face, all that stuff's going to get a decap BTLS. Just because you want to do your secondary assessment, you got to transport. You got to transport them first. You can do your detail on the way to the facility. Um, if multiple symptoms, or if multiple systems are likely to have been affected, start with the assessment to the entire body. I wanted to read that because that's very important right there. Do not delay transport. We've talked about that. If responsive, patients who has an isolated injury can, with a limited MOI, consider focus and physical examination on that patient, because they may not, you may be able to stay and play with them, but they're more serious. So let's go. Secondary assessment. Let's see here. Ensure that control of bleeding is maintained, and note the locations. Inspect the wound for any foreign matter and stabilize the impaled object. During the physical exam, use both of your eyes and hands. Your eyes will be looking for swelling, deformities of the bone, contusions, and discoloration. Your hands will be gently palpating the face, looking for feeling for any abnormalities. Let's see here. You want to also try to assess your underlying systems. You want to check your neuro, your sensory, your respiratory, and circulatory systems. All those are very important when you're checking the face for injuries. Hold on 2 seconds, let y'all read that. All right. So when evaluating the eyes, start with the outer aspect of the eyes and work towards the pupil. That's the most important thing. Visually, consider the vital signs of the eye. Gently cover one eye. Hold two fingers up at arm's length distance. Check their vision. Are they able to see the correct numbers? Brain injuries, nerve disease, glaucoma, and meningitis are other causes of unequal pupils. Ask questions. Look right here. Look for discolorations that could tell you jaundiceness or bleeding, redness of the eye, and the pupils, a reaction to light. Check those anytime that you're doing your detailed assessment. That's something you want to know. Assess vital signs to obtain a baseline so that you can observe any changes during treatment. Did what I did it improve their care, or did it not? So, and that's something you can notice by your vital signs. You may not. Oh, uh, uh, uh. Use appropriate monitoring devices to qualify your patient's oxygenation and circulatory. So you're going to use your pulse ox. Use the tools that you have to better treat your patient. That's very, very important. The reassessments, you're going to repeat the primary assessment. You're going to do this about every 5 minutes because it's going to be a critical patient. Provide complete spinal mobilization if necessary. That's going to be something that you're going to pick up off your general impression. Spinal injuries should be suspected at any time there is significant trauma to the face or neck. It's always to be safe than sorry. The hospital can take them off. They can remove it a lot easier because they got all the tools there. Recheck the patient's interventions. It is particularly important in the patient with a facial or neck injury because the ease in which injuries can affect the associated symptoms. Always recheck. Recheck. Interventions. Let's see here. Whenever you suspect a significant bleeding, provide high flow oxygen. If you have to provide with a BVM, always make sure that you have your proper seal. Um, Control any significant bleeding, which we already talked about that. That should be your number one thing. It may be a continuous thing that you have to continue to fix, but that is something that you want to continue going on. Reassess it. If once you got it controlled, are you having to add more bandages, or are you having to potentially add a tourniquet? If the patient has signs of hyperfusion, treat your patient aggressively for shock and provide rapid transport. Period. Right there. Period. Do not delay transport of a seriously injured patient to complete non life saving injuries in the field. Take that patient to the hospital. That's neglect. If you don't do it correct and you know that you did, that's neglect, and you're gonna get in trouble for that. If your documentation included a description of the MOI and the position in which your patient was found, I'm sorry. When you document, you need to document that. Include a description of the MOI in which the patient was found. That should be included in your chart. Especially with MVCs, MVAs, rollovers, T-bones, all those five different ways that a vehicle can be struck. You need to describe the vehicle. Give a small explanation, where the patient was sitting, were they buckled, were they not buckled, did you have to remove the buckle when you came up on them, stuff like that. That's very important for our officers later for court times, and if there ever is a fatality in the same vehicle, they're going to need to know that information, and these officers want to preserve the scene as best as possible. We know about communication. We talked about recognizing the estimated amount of blood. We figured out some skills for y'all to go do that. Pouring stuff on the concrete would help you out. Um, Inform the hospital with at least a far enough in advance that you can talk to them. If your agency says you must call them by phone or 10 minutes out, that's fine. We've always used the 5 minute approach where I'm from, 5 minutes out, or if I'm responding with a trauma, I'll call them 20 minutes out, and then I'll call them again with 5 minutes out. Or I've also had my partners give them a radio call as they're driving to the facility, um, because maybe I have my hands full and I just need them to relay some information. All right, so let's go a little bit deeper into this now. So, emergency medical care, we're going to hit this. Treat soft tissue injuries in the face and neck, and the same as a soft tissue injury elsewhere in the body. Check your ABCs, treat those life threats first. And in the absence of a life threat, open the airway and clear it. If the patient needs frequent suction of blood drained into the throat, make sure you have your tools ready. Avoid moving the neck. We know that you may have to put a C-collar or spinal mobilization on these patients. Once the patient is mobilized, you can turn the backboard on the side to allow blood or vomit to drain from the mouth. Oh, nope. Yep, that's gross. Make sure you're on the opposite side. Just letting you know. Control the bleeding with direct pressure. We know that. We've talked about that. If you have to use a roll of gauze, that's cool. Put your a layer of 4x4s down. hold some pressure, start wrapping your gauze around there. Do not take it off. Once you get it there and if it soaks through, continue to add more. Don't just undo it, throw it away, start over, because you're basically throwing away that clotting factor. That it's not allowing, if you continue to remove it and add more, you're not allowing it to clot at all. You're just soaking up the blood. And you need to allow it to potentially clot on its own. Uh, you don't, like what it says right there, don't apply excess pressure if you suspect a skull fracture, because you could potentially be pushing it back into the skull, and that's very dangerous. So be cautious on how you do that. When an injury exposes the brain, eye, or other structures, cover the exposed part with a moist, sterile dressing. Whew. Apply ice if you're able to. For soft tissue injuries around the mouth, check for bleeding inside the mouth. Broken teeth and lacerations to the tongue may cause profuse bleeding, which we know that. Often the patient will swallow the blood, so be expecting for them to throw up. And patients will swallow blood are prone to get very nauseous, and they'll tell you, I just don't feel so good. I don't feel good. Blah. There you go. That's the most head warning that you get, because they're constantly trying to swallow it, and they just don't know that it's blood, and they're like, oh, this doesn't taste good. Well, there's your sign that you're not swallowing something you're supposed to be swallowing. Uh, let's see. Physicians can sometimes graft a piece of avulsed skin back into the appropriate positions, or they can remove it from another part of your body and put it on there. If you find portions of avulsed skin, wrap them in a sterile dressing, place them in a plastic bag, and keep them cool. Ugh. Never you place tissue on ice, because freezing will destroy the tissues. Um, Make sure you take it with you. I've never really done that, but if you have the time, feel free. It's kind of gross, but rock on with it. If the avulsed skin is still attached, don't pull it. Leave it where it's at. Try to put it in its most correct position, and use a dry sterile dressing. Yeah, that's just gross. I'm sorry. Eye injuries are very common in some sporting events. They can produce obviously lifelong injuries, blindness, um, sensitivity to light. Uh, if there's any eye injury, it could entail the entire circle of the iris. The pupils are round, usually equal in size, and react equal when exposed to light. Shouldn't be painful. Both eyes move together in the same direction when following your moving finger. So the thing is, it's kind of cool. Get somebody to stand in front of you, kind of like do the DUI checkpoint. Have somebody stare at your finger and watch their eyes. They can't separate. They fall in the same direction. Some have these tricky ones that yes, they can separate and look opposite directions. I think that's kind of cool, but it's kind of gross at the same time. And watch the eyes. Look at something directly in front of you, like maybe the mirror. Raise your head up, down, side to side. You notice that your eyes really don't move. They'll stay in one place. Both of them will be focused at the same point. Ooh, after an injury, people reactions or shape and eye movement are disturbed. There's going to be some sensitivity, swelling, redness to that area. Abnormal pupil reaction sometimes are signs of brain injuries rather than an eye injury. May have some slow reactions. They'll be a little bit delayed. A damaged cornea quickly loses its smooth, wet appearance. It looks dry and just like it looks sick when you look at it up close. So foreign objects are huge parts of our field, specifically mine in the oil field. That's our number one injury, no matter what we have. Eye protection, face shields. I mean, it doesn't matter. Eye injuries are huge to us. So we right there it says even a small object may produce severe irritation. The best thing you can do is have them just close their eyes. Don't rub their eyes, because what it's doing is if there's something in there, it's scratching it, and then it's going to cause more damage and potentially scratch the cornea instead of just being an irritant. And you got to get it out. But if once it gets embedded into the eye, we can't do anything for that. You have to take them to the ENT and let them work that out. It says right there, the conjunctiva becomes inflamed and red, the condition known as conjunctivitis, and the eye begins to produce tears in an attempt to flush the object. Irritation of the cornea and conjunctive causes intense pain. Irritation with the sterile saline solution will frequently flush away, maybe. Use a bulb syringe or a nasal cannula a nasal cannula to direct saline into the affected eye. If you don't know how to do that, I think they should show you at boot camp. But please Google that, YouTube that, just kind of get an idea of how they use the nasal cannula and get it to go into both eyes at one time. It's kind of cool. It's a cool little trick to keep in your back pocket. So there's your picture right there of how they're doing it. They're holding both eyes open. Another partner, or another person is pushing the 60 cc's of normal saline into the eyes through the nasal cannula. It's kind of a lengthy process. It's a lot of stop and refill and go back and reset. But that's the overall picture of kind of how you do it. Kind of reverse it on the bridge of the nose. Make sure it drains into the eye. Foreign bodies will leave small abrasions, which we know that because we've all unfortunately scratched our own eyes. You've seen it get really red. If you spot the foreign object on the surface of the eyelid, you may be able to remove it with a moist, sterile cotton-tipped applicator. Not really sure how many ambulances have applicators on the trucks or Q-tips, but those are really good. You can look in your book on skill drill 27-1, and it should give you some explanations on how to do that. And never attempt to remove an object that is stuck to the cornea. It's not ours, it's depth, it's embedded, and there's nothing we can do about it no matter how hard we try. You just got to leave it where it's at. Foreign bodies must be removed by a physician. Yes, for our case, yes. Your care involves stabilization of the object and prepare the patient for transport. If it's an embedded or let's just say foreign object, so we'll stick with that. So you want to cover the eye with a more sterile dressing, and you're going to want the patients to close their eyes, because if you have a foreign object in the left eye and you close it, but the patient's looking around with their right eye, their left eye is moving too, so all it's going to do is cause more irritation. When you see or suspect an impaled object in the eye, bandage both eyes with soft, bulky dressing to prevent further injuries. This type of injury may be handled by an ophthalmologist on an urgent basis, which we don't transport to ophthalmologist office, we transport to ERs. So if you bandage one eye, bandage the other, and just tell them what you're doing and explain everything to them, because now you're taking a sense away from this person, and that may startle them a little bit more than what we regularly deal with. So keep that in the back of your mind. Burns to the eye, number one thing you want to do is stop the burning, prevent further damage, remove it if possible. Chemicals too, the same thing. They always caused by acids or alkaline solutions. Either way, those are the two things that do it. Flush the eye with water or saline. Direct the greatest amount of irrigation solution or water into the eye and as gently as possible. Here's pictures on how to do it. Nasal cannula. Oh, right there. Hang on. Nasal cannula. Eye wash station. I don't know what they're doing here. Maybe this is a baptism of the eye. I'm not real sure. And this one's they're trying to hold the eye open and pour saline in there. It doesn't look like it's doing a good job. These right here look like they're doing the best. Never seen that one right there, but I'm not gonna hate it. It might work. We'll leave it the way it is. I'm just checking something real quick. Okay. So chemical burns. You may have to force the lids open to irritate, because they're just the sensitivity is gonna try to squeeze as tight as possible. Let's say like pepper spray. God knows I hated getting pepper sprayed, but only the 16 times that I've had to get it done, and also out in the field. Um, you have to force the eyes open. They're not going to open on their own. So remember that. Use a bulb or an irrigation syringe, nasal cannula, basin, or running faucet. Like the other ones besides the basin, I'm not going to dunk my eye in there because I'm still trying to breathe. Um, you can even have your patient immerse his or her face. I guess that's what we were looking at. Cool. Flush from the inner cornea of the affected eye towards the outside. Um, if because you want it to drain out the eye, not stop right there by the conjunctivitis or the conjunctival gland, because it's going to back up in there and potentially become more irrigation. So if you can start on the inner towards the nose and flush it outward, that's the best way because it'll flush down your face and be good from there. Um, if the burning was caused by an alkali or strong acid, you should irrigate the eye continuously for no less than 20 minutes. Period. And right there it says, after irrigation, apply clean, dry dressing and cover the eye and ready for them for transport. Thermal burns. Whoo, no thanks, I'm good. Thermal burns. During a fire, the eyes will close to protect from heat, which we know that. We kind of all see that ourselves. Transport promptly without further examination, because you irritate the eye and the more and more it's going to swell. And whenever you get to the facility, the hospital is not going to allow them to be able to check the eye like they need to, because we've already screwed with it enough to where it's swollen. If your agency has eye shields, not as in like the 2x2 iPads, but the eye shields are metal protective pieces that cover the eye. You can lay those on there and then dress the face. Hold them in place with some Curlex, but remember, you want to do it so that it's easily removable and that they can still breathe. So when you wrap it, keep those in back of your mind. And when you do, maybe if you wrap around the side of the face, don't cover up the ears, because they kind of start losing senses and it kind of starts to have them freak out, and you may notice that in some anxiety issues. Light burns, these are kind of cool, like sunburns. Sun can burn your eyes, which is the infrared. The laser beams, eclipse light, like if you're looking into the sun too long, welding burns, all those fall underneath this one. It may not be painful at first, but become very painful 3 to 5 hours later. Severe conjunctivitis usually develops with redness, swelling, and excessive tear production. You can ease the pain by covering each eye with a sterile, moist pad and eye shields. The patient should be examined by a physician as soon as possible. I've treated a lot of welding issues, welding burns in the eyes, because they were trying to quick weld and get a good tack, and it just didn't work. So now that their eyes over time, and some of the guys that weld for hours on end, that's where they get their burns from. And they'll come see you. Most of the time, they need like in my state, they'll need like 1 or 2 days of eye drops, and then they're good from there. They may not, like we may take them off of welding for 12 hours because it helped their eyes heal a little bit better, but they can continuously get it, and it will over time cause them blindness too. So that's something you have to be careful about. Some lacerations to the eyeballs require a very, very careful repair. Bleeding, yeah, it depends. If you have something that scratched the eye, poked the eye, or penetrated the eye, yeah, you'll see some bleeding there. Compression can interfere with the blood supply, so be cautious of that. Some people may not be able to tolerate the pressure either, but if you're trying to control the bleeding, it may just be easier for you to hold it there, and that way that you know the consistent pressure that you're applying. Uh, Never exert pressure or manipulate the injured globe. You don't want to try to move it around or palpate for any other injuries. Leave it in place. Right there, we told you earlier, cover with a protective metal eye shield. That's if your agency has that. I don't know how many agencies still carry those. We do for what we do out offshore. but I've never seen one on an ambulance. Apply a soft dressing on both eyes to provide transport because, again, we got to secure both eyes because if the left eye is injured, the right eye is going to try to look everywhere and the left eye is going to follow it. So that's why we want to cover up both. On rare occasions, the eyeball may be displaced from the eye socket. That is gross. That is not what Chris Wally wants to deal with. I don't want to handle that. Nope, don't want to do it. And I'm definitely not going to reposition it because it's against our practicals. We can't do that at all. The best thing you can do is have, in my case, have your partner cover it, keep it moist, keep it stable. Uh, if it's just one eye, cover it, both eyes, and have them lay at a 45, if not lower position. And Chris Wally will drive to the hospital while you take care of the patient. Just gonna let you know. Not doing it. Not today, Willis. So some blunt trauma. So injuries range from the ordinary black eye to severe damage to the globe. So those are serious ones we got to be careful about. We talk about right here the hypemia is cures all or parts of the iris. Cover the eye to protect further injury and provide transfer. So do y'all understand out of this entire issue on eyes? We just want you to cover it and cover both of them in transport. That's really what I have gone over this entire time is that they don't want you to forget about to cover and transport. Jesus. Oh, let's see here. Never mind. We'll go on. One pupil larger than the other can potentially show you of a head injury. Failure of the eyes to follow the movement of your fingers can be head injuries or DUI. Bleeding under conjunctiva, which is the pink part, protrusions or bulging from one eye. These are all different types of head injuries. Uh, and I guess what they want you to do, cover the lids and transport. We got that, bruh. So blast injury is a little bit different when it comes to eyes. This is where we're going to have some issues. Um, So before responding to a patient's after blast, make sure the scene is safe, period, that no other secondary or tertiary blast is potentially in the area. Be very, very, very aware of your surroundings. If there's foreign objects, foreign body in the globe, do not attempt to remove it. Use a clean cup or similar to protect the eye. Let me guess, cover it and transport. Patients with sudden loss or decrease of vision will have to be verbally instructed on what's going on around them, and they're going to have very high anxiety. So remember that. If the patient has severe swelling or hematoma to the eyelid, do not attempt to force the eyelid open. Do not do it. Leave it where it's at, take it for what it is, and transport that patient to the facility that needs. Contact lens, just leave them. That's the best thing you can do. Just leave them there. Let somebody else take them out. That's not our problem. I know it says right here to remove Nalka. Just leave it. I promise you. They gonna mess with that eye way more than we are, and if we don't want to keep the swelling going on, because all it's gonna do is make it worse. So just leave them. I promise you, it'll be better off for you. So I guess they're trying to tell you how to remove contacts, but I'm just gonna tell you don't. And for the ones that have contacts, just let it be. Let it be in this patient. Just work it out that way. Um, I'm just gonna go ahead and go forth on that. All right. So nosebleeds, epistaxis. Make sure that they stay leaning forward. It's usually sometimes they quickly resolve. Sometimes they may not. Sometimes it may require our assistance. Let's see right there. Posterior nosebleeds are usually more severe and often cause blood to drain into the patient's throat. That's why we say have them lean forward. Attempting to insert a nasopharyngeal airway in a patient with a suspected basilar skull fracture or with facial fractures is controversial. Make sure, I'm going to say this loud, follow your local protocols on what you're supposed to do if you suspect a basal skull fracture. Um, the nose, yeah, you're gonna catch some injuries from car crashes because this person got their butt whooped. Blunt force injuries, you may notice there. I see if y'all watch the show out of New Orleans, I forgot what it's called. They were talking the other day that they had a call because this dude's nose was hanging off his face. I haven't seen it yet, but I'm sure at some point we all gonna have some weird shit like that that we gotta deal with. So just treat what you find. If you're not comfortable, guess what you're gonna do? Cover it and transport to a local facility. So here's parts of the nose, so you can understand where the sinuses are, the septums. So here's kind of a cool thing. So when they test you for COVID, they come through here, and they're gonna come right here to test it. Okay. So that's the reason why if they don't do the nasal swab, it sends to a lab and it comes through here. They're only testing your boogers and the snot that's on the inside of your nose. With us at SMS, this is where we teach, and we should go all the way till it stops, twist it, and pull it out back out. We're not going to shove it in your face. They're not comfortable, but at the same time, it's not painful. You can make it. I promise you, I get it done all the time. Injuries to the nose. You could have some CSF, may escape through down the nose and fall into fractures to the base of the skull. Depends. We want to take a piece of gauze. We'll apply that blood on there. Look for the halo effect. That'll tell you if it's anything there. Consider cervical spine injuries, especially like if you go to an MMA fight, a boxing fight. Always put them in a C collar because obviously they just got finished beating the crap out of each other. Until we know what's going on, don't take it off. Let somebody else higher than us do it. For a non-traumatic patient who is bleeding from the nose, place the patient in a sitting position, lean them forward, and pinch the nostrils together. On skills 2531, you'll see that in your book, and always have multiple 4x4s by you. And if you transport pretty rapidly to a hospital, I'm not saying lights and sirens or nothing, but if you're close, don't worry about removing that. Let them do that at the facility because it's kind of gross. After a while, it just clots up and clumps fall out, or it can potentially start bleeding again. So let's think about that. So always have multiple 4x4s handy when it's time to treat a nosebleed. Ear injuries. So you have your external, middle, and inner. Here's a good picture to show you right there. So right here is all from about right in here before you hit your eardrum, outwards, all outer ear. Your middle ear goes from your inner eardrum to your stirrup, I guess what they're saying, and down in here to on the deeper part of the skull side is going to be your inner ear. So that's your eardrum, tympanic membrane. That's what makes all the sounds and all that. So you get all your earwax up in here. People get all these pierced. But you can rupture your eardrum and all these other things and can cause you some dizziness, your gait will be off. So now you know what it looks like. But there's the hammer. In case anybody was looking for one, it's right here. We found the hammer. Don't worry about it. All right, so here, we'll go over this one. Pretty cool. In a case of an ear avulsion, wrap the avulsed part in a moist, sterile dressing and put it in a plastic bag. Label with the patient's name, and probably would be the best interest to you on what side of the body it came from. Y'all will be amazed. So the tympanic membrane rupture, you'll have sudden changes in pressure created by a blast or wave, may cause a rupture. Patients will report severe pain, difficulty hearing, and ringing affected in the ear. I promise you, the ringing is horrible. Sometimes I still hear it, but I didn't rupture mine from a blast, but you'll have a lot of ringing of the ears will be there. Let's see. Patients with a suspected tympanic membrane injury, they need to go to the hospital to get evaluated. I mean, obviously, we can't do anything for them out in the field. We don't have the otoscopes to look in their ears and check their eardrums out and stuff like that on an ambulance. But they need to go. Children that put stuff in their ears, man, they gotta go too. Even if we can see it, we can't remove it with our tools. We need to let them go to make sure that there's nothing been wrong with the ear or nose or anything like that. And specifically, if we see clear fluids coming from the ear, they must go to the medical facility to be treated. Because until proven otherwise, all you can think of is that CSF. So let's make that stay important and get it treated and checked out, because then it makes us look good because we did the right thing. Facial fractures, most of the time it's from blunt injuries and from your fist. Uh, all sorts of things can cause that. Let's say here, you should assume that any patient who has sustained a direct blow to the mouth or nose has a facial fracture. You see some of the things that you may include right there. Some of the injuries, some clues that you may look at. Facial fractures. Facial fractures alone are not acute emergencies, unless it's deep, lots of bleeding, in which we know the face, head, neck, and face is gonna bleed a lot because it's very veiny. The skin's thin. Um, Plastic surgeons can repair damage to the face as long as treated within 7 to 10 days. Remove and save loose teeth or bone fragments from the mouth because it's often possible to replant them. Remove any loose dentures or dental bridges to protect against airway obstructions. That's very important. I promise you, later in your career, you'll remember that. Another source of airway obstruction and swelling, which can be extreme and within the first 24 hours. Take those out the way. Get them moving. Let's get those out the way. But make sure you transport those with the patient to the facility and letting them know that these teeth go to Mr. Jones. Those are his, because Mr. Jones paid a lot of money for them teeth. Dental injuries. Most people are gonna freak out about that. They're like, "Oh my God, my teeth! Why am I holding my teeth in my hand?" It's because you just ate the steering wheel, sir. You didn't wear a seatbelt, and now your teeth are all over your car. So there you go. Bleeding will occur if a tooth is removed violently from its face. I actually transported a guy the other day that had 6 teeth pulled and that would not stop bleeding. It was pretty gross, but he was on a very heavy blood thinner, and I have no idea why his primary care physician told him that that would be okay, but that's on them. It took hours for them to get the bleeding to stop. So it's not like something that was just super easy. Um, it did take a while for the bleeding to stop. So, you know, just remember that sometimes that you're going to try to remove, get them to remove the teeth, and they're going to freak out. So that's going to be one of the things that you have to recall is to fix that. Hold on 2 seconds, folks. All right. Cracked or loose teeth or possible airway obstructions. Perform suction if needing, and you can also teach them how to suction. If you're doing something else, be like, look, hold this in there. Anytime you feel like you need to spit, let's just suck it out. That happens a lot. Place a tooth in a storage unit, solution, cold milk, or sterile saline. Notify the receiving facility of an avulsed teeth. Uh, they can take, as you see it right there, reimplantation is recommended within 20 minutes to 1 hour after the trauma. I've heard of it going longer, but I don't really tell you. I like my teeth, and I would prefer to keep them in my head, so I don't want to find out. In case y'all do, y'all let me know. Injuries to the cheek. You may encounter an object impaled in the patient's cheek. Um, if you're unable to control the bleeding, it does compromise the airway. That's the only time that you can remove it. If it's impaled in the cheek and it compromises the airway. If they're breathing fine, then leave it. Um, the amount of bandages also depend on the patient and um, if the bleeding, if it's not bleeding a whole bunch, then they're good to go. Stand by. So remember that this one right here. If you're unable to control the bleeding, consider removing. That's the only time, and it obstructs the airway. Period. That's it. Um, the neck contains many structures. Y'all know about this. We've been over this. We showed y'all earlier where the cricoid cartilage is, the thyroid cartilage, uh, the cricoid arteries, and the jugular veins. We've gone over this in the airway, so y'all should know the anatomy of the body and why and where it's at. Sorry, I know y'all see my mouse running around, but just ignore it. I'm trying to multitask doesn't really go too good. So blunt injuries, steering wheel, attempted suicide by hanging will be some of these that you may notice. Clothesline injuries sustained when riding bicycles. That's funny. Any crushing injury of the upper airway part of the neck is likely involved in the larynx and trachea. So be careful of those. Those are serious. We got to treat those fast because they can start swelling and occlude the airway, and we don't want that. Let's see here. Subcutaneous emphysema is characterized by cracking sensations produced by the presence of air in the soft tissues of the neck. It sounds like snap, crackle, pops when you're palpating the neck and you feel the air moving through the skin underneath the skin. It's like it's kind of cool. I've seen it obviously in deer when you skin deer, but that's the biggest time I've seen it, not in a person. If you feel this was palpating the neck, maintain the airway as best as you can and transport immediately. Call for an ALS unit to meet you. If possible, and these incidents involving an injury to the throat, you may want to use cervical spine precautions. That may be as just a helpful for you, just to get them there, get them treated, get them, they may be like, why you got this stupid thing on their face? It's because I felt comfortable. That's the easiest way to do it, and they'll be all right. And then say, hey, can you teach me something better? And most of the time, the nurses and doctors are like, okay, I got to do this, because they don't know. They just like to talk trash. Sorry, that's my little poke on the hospital staff. Penetrating injuries. Penetrating injuries to the neck can cause profuse bleeding from laceration of the greatest vessels in the neck. Injuries to the cricoid or jugular veins in the neck can cause the body to bleed out. It can produce so much blood coming out of there. Let's see. Injuries to the large vessels may also allow air into to enter into the circulatory system. If a vein has been punctured, air may be sucked through to the heart. This condition may be created by an air embolism. A large amount of air in the right atrium and right ventricle of the heart can lead to a cardiac arrest. It will lead to a cardiac arrest. Uh, You may find it necessary to apply direct pressure above and below the penetrating wound to control life-saving bleeding and maintain cervical spine immobilization if necessary. Period. See collar and some bandages. And make sure if you put it on and something is protruding into the nose, you're probably not going to be able to keep a C collar on, but if it's to the throat specifically, you always want to try to keep an eye on that. Laryngeal injuries, blunt force to larynx can occur. We talked about here unrestrained drivers. I'm not going to say just snowmobile. We'll say four wheelers, ATVs, even, I mean, all of those can cause injuries to there. Some of the strangulation injuries can also be found in either in intentional or unintentional hangings. Anytime there is suspected injury to the larynx, it's possible to suspect cervical spine injury because it's to the throat and to the neck. They're so close that you just don't know. It's easier to say, let's just put them in a C collar because I don't know what's going on. They have X-ray at the facility. We don't. We're just going off of our spidey senses, and we want to do what's best for the patient. Penetrating or impaled objects in the larynx should not be removed unless they interfere with CPR only. Stabilizing impaled objects if they are not obstructing if they are obstructing the airway. Um, just I don't know. I've not run across that in my career to be able to tell you some advice or some story to help you perform that. But just be very cautious. Just know you don't want to remove it unless it's causing an issue with CPR. It's the only time you want to remove it. So here are some signs and symptoms of some injuries to the larynx. Y'all can see those right there. Um, I'm sure at some time we've all had those, but it's not necessarily saying that we had some laryngeal injuries like hoarseness. Sometimes it's okay if you can't talk. A lot of us would probably be happy, but I'm just picking. Some signs and symptoms right there. Bruising to the neck, hematomas. You may have some bleeding. Subcutaneous emphysema. That's kind of dangerous. You want to do provide oxygen, apply cervical spine, but avoid rigid collars. Rigid collars are like we call them money makers. Always be cautious. Make sure that they're safe, they're protected, and taken care of very well. Ladies and gentlemen, there is the conclusion of your class. I am sorry for the delay. I apologize that my technology mishap has caused some delay in some of you guys. I will extend this class 5 days from today when I post this test. Today is April 5th, so I will make the test go off at April 10th at midnight. Don't forget your other classes that are out there. So class on the 6th, that test will go out on the 11th. So you won't be able to take those. So guys, please, please, please email me if you have any questions. A lot of y'all have taken the benefit of sending me direct messages through Facebook, and I will help you out as much as you can. Please read your chapter also before you take your test. That will give you a better idea. And again, if anybody has any questions, please let me know. But your class code and your for your attendance also is 2, the money sign 7 question mark 7. It is 2 money sign 7 question mark 7. Hope you have a wonderful day, evening, morning, good night. I don't know what y'all are doing today, and I will see y'all at a later date. Y'all have a great one.